talking about pharmacodynamics. That's well, the conflict of interest has not changed. If we look back at the slide I showed you previously, we are now dealing for the concentration effect relationships. That's to say pharmacodynamics. And I shall focus on two main classes of drugs which we have in anesthesia and are hypnotic drugs and opioids. All anesthetic drugs interact with receptors. And you know this very well known drug receptor complex with here the equilibration dissociation constant, KD, which is the concentration of the drug that occupies 50% of a given receptor population. The drugs that will link to the receptor are called ligands, and you can classify them by their effects. Most are agonists and can be full agonist, partial agonist, or biased agonist, and some are antagonists. And it is important to know that when an antagonist is given alone, it doesn't produce any effect. It will only link to the receptor when there is an agonist on it to counteract with this agonist. So now we shall look at the sedative hypnotic drugs and their main receptor, which is the GABA receptor. The GABA receptor is a transmembrane receptor, and it has 5 subunits, and the different drugs will link to different fraction of this receptor, different subunits. It will link benzodiazepines, propofol, neurosteroids, ethanol, volatile anesthetic, etc. And when two drugs interact with different subunits, usually their association is synergistic. There is another very important receptor, which is the NMDA receptor, which is a glutamatergic excitator receptor. It links two categories in drugs in anesthesia, the opioids, and this is an unwanted effect leading to, for example, tolerance and hyperalgesia. And it links also a specific category of sedative drugs, which are ketamine and nitrous oxide. And this allosteric binding site of the receptor modulates the receptor function. And so the inhibition of the NMDA receptor by ketamine or nitrous oxide will be able to reduce the hyperalgesia conveyed by the opioid action by modulating the receptor function. How can we monitor the effects of hypnotic drugs? With increasing concentration, you will have, with the GABAergic drugs, progressive increase in the effect from anxiolysis to unconsciousness and immobility. Of course, it is fairly easy to measure at induction of anesthesia the step between anxiolysis to unconsciousness because there are several parameters that can be monitored. Loss of verbal contact, loss of eyelash reflex, and hypotonia. That's to say the dropping of his syringe put into the end of the patient. Then at recovery, you can see the coming back of consciousness by returning of verbal contact, for example, and you can assess that there is no conscious recall of what happened during surgery. But in between, it is very difficult, and you have no clinical endpoint to measure cerebral activity, specifically if a patient is paralyzed. If a patient is not paralyzed and he or she is conscious, he or she will open their eyes. So you know that they are conscious. But in a paralyzed patient, you cannot know. And the only way to assess the level of consciousness is to look for surrogate measures of cerebral activity by analysis of spontaneous cortical EEG or evoked cortical EEG analysis. There are quite a number of surrogate measures of hypnosis which have been used to assess what's so-called depth of anesthesia or level of anesthesia. The best known and one of the first ones is the bispectral index. There is also the entropy from GE, the SEDline, currently with Massimo, the narcotrend, and the auditory evoked potentials. Most of these measures are based on spectral analysis. In spectral analysis, you decompose the raw EEG here in a series of sinusoids, each one having its own amplitude and its own frequency. As it is very difficult mathematically to study the amplitude, positive and negative, of sinusoid, they are usually squared so as to have always positive values. And this is called the power of a sinusoid. It has been used to build up spectrum, power spectrum of the EEG. Those surrogate measures are statistical. They are statistically correlated to the absence of consciousness. And this is very clear on this important paper published by Peter Glass quite a long time ago, where you see the concentration of propofol and here the level of consciousness. In the open circles, the patients are conscious, and in the plain full circles, the patients are unconscious. And you see that about 3 to 4 micrograms per mil propofol, there is a zone where some patients are conscious and some are not. Whereas if you go over 4 micrograms per mil propofol, all the patients are unconscious. But some are unconscious at very low propofol concentrations. So this is statistically correlated to the absence of consciousness. So when you want to estimate the effect of hypnotic drugs, you can use surrogate measures. They are statistical, and you have to put them in perspective with the clinical state of your patient. They monitor an individual patient, and just to remind you that at similar values, the risk of recall is the same with intravenous and volatile agent, whatever some people may say. Look at the literature. Another way to estimate the effect of hypnotic drug is to look at drug concentration. Of course, for intravenous drugs, the drug concentration will be also statistical estimation, population estimates of predicted concentration. But with a volatile, you are more confident because you say that alveolar concentrations are measured. But always remember that what you measure is alveolar concentration and not effect site in volatile agents, unless you have a device which can calculate the effect site concentration of volatiles. Let's have a look now at opioids. Opioids act through opioid receptors. The opioid receptor are G protein combined transmembrane receptors. You see here the opioid receptor linking to its G protein to activate or inactivate the adenylate cyclase, and so modifying the transformation of ATP in cyclic AMP. There are currently four opioid receptor subtypes known in the literature. Three of them are well known for a long time, and you know them all: the mu receptor, the delta receptor, and the kappa receptor. But there is a new one, which is called the NOP receptor, because its natural ligand is called nociceptin-orphanin, and this peculiar receptor. The NOP receptor, structurally as a molecule, is an opioid receptor. And also, you will find it in systems where endogenous opioid play a regulatory role and where you find other opioid receptors. So it is an opioid receptor, but it differs from the other ones. And for example, it has a specific antagonist, and it has no affinity for naloxone and the other antagonists. In fact, it should be considered as a non-opioid branch of the opioid receptor. Its functions are as yet not completely understood and are under study, but its interest in pharmacology of anesthesia is that currently a research field very important is to identify ligands that act on several opioid receptors, the idea being to maintain or enhance the analgesia and limit the deleterious effects. Those are called bivalent ligands, and one of those is currently at the end of its phase 3 studies, so close to be marketed, and is called sebronopadol. Sebronopadol acts on mu and NOP receptor agonists. It is an analgesic, but it is also an anti-hyperalgesic, which is, of course, very important. It will induce a moderate respiratory depression with a saline effect. It has little addictive potential, nearly no tolerance. Like all the opioids, it will induce nausea and vomiting at high doses. And it is presented nowadays for chronic pain, cancer pain, low back pain, etc. Let's go back to our opioid receptor. We have seen the coupling of the receptor to the G protein, leading to an inhibition of the adenyl cyclase by the opioids. But there is another way. Another way is the MAPK activation, which is responsible for the unwanted effect. And this will act through another molecule, which is called the beta-arrestin. The role of the beta-arrestin is to uncouple the receptor and the G protein, leading to the end of opioid action. But it also stimulates the MAPK and thus has an important role in the generation of the unwanted side effects. So, researchers in molecular pharmacology are trying to create biased agonists, that's to say agonists which are more active on the G protein pathway than on the beta-arrestin pathway, hoping to get more analgesia and less unwanted effect. And one of those molecules called aliceridine has received approval from the FDA nearly 3 years ago for acute important pain in adults, and thus can be used for postoperative analgesia. The aliceridine is a biased agonist. It generates opioids unwanted effect, but less than morphine. Its small name, marketed name, is Olinvic. So now a few words on monitoring the nociceptive-antinociceptive balance. It is more complicated to measure the nociceptive-antinociceptive balance than the hypnotic sedation step. And one of those reasons is that you measure the answer to a stimulus, but you cannot anticipate the stimulus. One of the easier way to measure the opioid effect in a spontaneously ventilating patient is to look at the respiratory rate. Here it's breath intervals, so the shorter they are, the more the patient is breathing quickly. You see the stimulus and you get an increase in respiratory rate, and the same with another stimulus. This is the easiest way to measure the adequacy of the nociceptive-antinociceptive balance. Another clinical measure of this balance is the infrared pupillometry, like this photo taken from Luc Barvet's study in 2003. And you see here that with increasing predicted remifentanil concentration, you have a reduction in pupil size, which can be correlated to the concentration. Of course, it is true mainly for low opioid concentration. Another way to estimate opioid concentration is to look at arousal reaction. If you give a painful stimulus to a patient who is unconscious, you will have brutal, important increases in the base, for example, and cortical EEG arousal reaction. And here there are young women having breast surgery and lymph node removal, and you see that intubation, first skin incision, second skin incision, arousal reactions with rather low concentration of alfentanil. If you increase the alfentanil concentration, you don't have arousal reactions anymore. Nevertheless, those are fairly impressive assessment of the balance. And so various analgesia monitors have been put on the market to try and measure the nociceptive-antinociceptive balance. And you have them here, some of them listed. Of course, there are others. The most interesting today is the nociception level, better known as NOL, which is a very complex parameter, but gives rather good results in clinical studies. The main problem, and I shall repeat it, is that all these monitors react to the stimulation and they don't predict reactivity. The only way to predict reactivity is to consider hypnotic and opioid concentration and their interaction. If the hypnotic and opioid concentration are high, the patient will not react to your stimulus. A few words on hypnotic opioid interaction. The concentration effect sigmoidal Emax model which you know very well. And here, for example, for alpha-fentanyl, you can see that the sigmoid is not the same for different stimuli. When you apply an adrenergic stimulus, you will have, for the association of a hypnotic, whatever the hypnotic, and opioid, whatever the opioid, you have a profound synergistic relationship. And you can see here, if you put very high hypnotic concentration, you will blunt the response. This is not the case. The response, this is the MAC curve, as you have already understood. So it's movement on skin incision, and at very high opioid concentration, the patient may move, not because he is painful, but because he is conscious. And the requirements to control different reactions are different. And you see here the classical curve published by Cato, where you have the MAC, a dotted point here, the MAC away, that's to say the loss of consciousness. And you see here and here you have the MAC bar, which is the hemodynamic stability. And you see here that the MAC bar and the MAC away crossed, and you can have here patients conscious, but with a very good hemodynamic stability. Let's say only that on your ventilators, the MAC which is displayed is this one and only this one. And it hasn't got much to do with the actual state of the patient. Well, you will look at this paper by Charles Minto on response surface model, which I don't have much time to talk to you about. But compared to the isobol that I showed you previously, it will look at the whole family of effect from no effect to maximum effect. And so this is better to interpret the action of the drug, of both drugs. There are a few devices currently on the market which display the interaction. And for example, this is a smart pilot view from Draeger. It has several interests. First of all, it calculates a nociceptive stimulation reaction index, which can be linked to the probability of response. And also here you see that there is the curve here, and here the surface, and this is the volatile measure, the volatile concentration of desflurane here. No, it's here. This is remifentanil. And here you have the volatile concentration, and the curve actually calculates the effect site concentration. Donc here you will have the proper effect site concentration of your volatile drug. So, and as a conclusion, I will say that ongoing advances in receptor research allow a better understanding of the mechanism involved in anesthesia. It also allows the apparition of new drugs with less side effects. And in everyday practice, to assess the pharmacodynamics and time course of action of a drug, you may rely on predicted or measured concentration or direct monitoring of drug effects, and probably in difficult cases, the two linked may give you a good appraisal of the state of your patient, and some will allow the display of pharmacodynamic interaction, which is also very important. And thus you can ensure better control over the drug effect relationship in any patients. I thank you very much. Which are the main neurotransmitters associated with hypnotic action? Well, but it's the GABA, and with the ketamine and nitrous oxide, it is the anti-NMDA, so it is the glutamic and glycine. Can't you estimate unconsciousness and absence? To estimate unconsciousness and absence of recall in a paralyzed patient, you can statistically either rely on predicted or measured concentrations, or on surrogate measure of the hypnotic effect as obtained with the various monitors such as BIS, entropy, SEDline, etc. How can you predict the absence of response to adrenergic stimuli? Well, the only way to predict the absence of response is to rely on predicted opioid and hypnotic concentration and their interaction. The analgesia monitor do not predict the absence of response.